So I want to discuss active surveillance for favorable risk prostate cancer, and we do have a study and a program for this at the cancer center, as Dr. Jatsakian mentioned. You know, a lot of I'll get a little bit off my slides for a minute, because to me, a lot of the recent debate, as I read it, seems to be that if your PSA is 4.1, you get a biopsy. If you have cancer, you get aggressive treatment. If you get aggressive treatment, you have horrible quality of life issues. And basically, none of those are true. We look at a lot of different things to decide who needs a biopsy, a lot of things to even decide who needs treatment, and the treatments have become a lot less morbid. But I think really the biggest thing is, finding physicians who really staying on top of the literature and realize that just basically not everybody needs to be treated, including at younger ages. I hear a lot of people actually still hassle me about the whole medical legal thing of how can you tell people not to get treatment? What if it spreads? What if there's problems? Aren't you worried about being sued? And I think if you really base on practice guidelines, base treatment on what we know from the literature, that it's a very good approach for select patients and patients who understand what they're getting into. A lot of the data in each of our talks is going to get to be a little repetitive, because I think we've prepared our talks for times when we're not all speaking together. But lifetime risk, about 17% of men are going to be diagnosed with prostate cancer. Fewer than 3% of men are going to ultimately die from prostate cancer. In autopsy series, they find that a lot of men have latent or undiagnosed prostate cancer, which it's just further evidence that most men are dying with it instead of from it. Other cancers that are known to be more aggressive, you don't find incidental pancreatic cancer on an autopsy study. And because of this, that's how we know that a lot of cancers are overtreated. There are a lot of men who simply are not going to go on to die from prostate cancer if you leave them untreated. We've got a lot of controversies, pro and con, about PSA. That's all been gone over very nicely. And as I was saying, if the treatment doesn't, if the diagnosis doesn't automatically lead to a radical treatment, then to me the PSA screening becomes less controversial. It's simply another tool. It's another piece of information that we can all use. You don't have to as much of a fear in the pros and cons of counseling patients about every PSA test if you're not automatically getting a biopsy, automatically getting radical treatment. The biggest thing then is trying to figure out who not to treat, and this is still evolving, and we're still trying to find out how to do this. So, why do we want to not treat prostate cancer? Well, all of the treatments have side effects. Surgery, cryoablation, radiation are mainstays of treatment. All of them are going to have long-term side effects on urinary control, erectile dysfunction, sometimes bowel dysfunction. Surgery certainly has significant recovery. Brachytherapy less so, cryoablation less so. Radiation, frequently you're going 5 days a week for 6 weeks, so the treatment time is a big concern. So there's certainly a lot of issues where it's not just a simple outpatient treatment with no recovery. And we do know from a lot of good studies that you don't have to treat prostate cancer immediately. Again, going to autopsy studies, we find that men in their 30s and 40s on autopsy series, we find prostate cancer, and we're never clinically diagnosing it at that age. So we know that it's developing in your 30s and 40s. We know that we're finding it in your 50s, 60s, and 70s. And because of that, we know that there's this slow subclinical growth, 10, 20, 30 years. We know from that point the progression of metastases and dying from cancer is 10 years, 15 years, maybe even 20 years. So there's this concept of this long window of curability, because if we were finding prostate cancer at its first sign, we'd be diagnosing it in men in their 30s. And we just certainly know that that's not when we're finding it, and that men are not dying in their 30s and 40s. So especially with the low-risk disease, there's a long time horizon where people are still curable. And if we look at the kind of the criteria for low risk, high risk, intermediate risk, up to around 84% of men, certainly a very significant number of men who are diagnosed with prostate cancer probably fall into this low risk category. There's this whole older concept, watchful waiting, versus when we talk about active surveillance. And on one hand, it's semantics. On the other hand, I kind of hate to say it's not semantics. When we talk about watchful waiting, it was your older patient with medical disease who you were just going to wait, do nothing, and when it became metastatic, you'd put them on hormones. And it's because there's that concept, that's why we wanted to come up with a different name. And with active surveillance, it really is much more of an active surveillance. The idea is to watch people closely, close monitoring, which we'll get into all those details. And the idea is that if there's any sign of progression, you can still proceed with curative intent, whether that's surgery, cryo, radiation, whatever it is. So the idea is that to try to leave you alone if we can, but still catch it while it's curable. Low-risk disease, there's criteria certainly. We look for a Gleason score of 6 or less. Tumor stage T1C means things are found by PSA only. You can't feel a palpable nodule. T2A would be basically a small palpable nodule. So low stage, low Gleason score, PSA under 10, and we know that these people are very low risk. And with all the people being screened, we're finding, the vast majority of men that we're finding prostate cancer in are falling into this low risk category. So people have tried to say, how are we going to monitor these patients? Who's going to get in? How are we going to watch them? The entry criteria, the idea of the entry criteria is just low-risk patients, as we just went through. PSA less than 10, probably non-palpable disease or a very small nodule, low Gleason scores. And then also with biopsies now, this has evolved. It used to be what we called sextant biopsies, 6 cores. Now that we give some anesthetic around the prostate, we routinely do 12 cores. And so with a 12-core biopsy, we're saying if you have only 1 or 2 cores with cancer, no more than 50% of any core, it's got to be a pretty small tumor. So as long as you have a small volume pathologically and low-grade disease, we probably can watch you. The follow-up, it might be overkill, but we haven't decided yet how loose we can be. So every 3 months, we see patients that get a PSA. I'm doing every 6 months a rectal exam. Patients are happy to skip prostate exams as much as we can. And we're doing the biopsy at year 1, 3, 5, et cetera. I like to do it the first year just because there is some sampling error, so there's some potential for understaging. So it's a good idea to get another pathologic diagnosis, not waiting many years for that. So a lot of men that we diagnose do fall into this category. Who do we decide is progressing and probably needs treatment? Well, the PSA has maybe risen to over 10. Stage progression, you've gone from no nodule to a nodule, you've gone from a small nodule to a big nodule, so clinical stage progression. And then if the grade on the grade of the cancer on biopsy is changing. So if it was low grade, that's great. Now you're coming in at moderate or higher grade, maybe we ought to do something. And again, it's taking anything bigger than our entry criteria. So now suddenly you're having more than 2 cores, more than 50% of a core. It indicates that you've got a bigger tumor within the prostate. And then we also look at the PSA kinetics. So PSA doubling time of less than 3 years or that significant rise, 0.75, 18 months. It's looking at a way of seeing who has a rapidly rising PSA, because despite a low-grade, low-risk biopsy, perhaps they have a rapidly growing tumor. Just a few groups out there that have been doing this for a long enough time to have some data. One of the bigger studies, because obviously it's hard to enroll a lot of people and get good data, average 6-year follow-up, about 300 patients. By 6 years average, they found that about 2/3 of the patients were still on surveillance. So that, to me, I think that's a pretty big success. The 2/3 of the patients avoided treatment. About 1/3 came off of surveillance. And it was for differing reasons. One of the important things is about 12% was simply patient preference. They got sick of watching, it started to bother them, they wanted treatment. And yes, that should be counted in people who come off of surveillance, but it's interesting if you add that back in, now you're at 78%, maybe you round that off to 80. About 80% of people are still meeting all of the criteria for surveillance, and only about 20% of patients actually have any signs of the cancer growing. So it's really, even with our screening criteria, we're doing a pretty good job. So some patients it was for PSA rise, some it was for a newer growing nodule, some people the grade went from 6 to 7. The overall survival in this group, about 85%, but most importantly is the disease-specific survival, because, of course you go and, die of a heart attack or something else, that may not be, well, from a prostate cancer standpoint, isn't as important. The disease-specific survival, 99%. There were 3 deaths from prostate cancer, and I don't mean to kind of come up with reasons to explain it away. You do have a chance on surveillance that you could die of prostate cancer, but these men, if you really look at it, they all had extremely rapid rise after diagnosis. They all needed to begin treatment within 1 year. So if you look at all these people rapidly progressing to bone metastases and treatment, it sounds like most of these guys probably weren't going to be cured by surgery or treatment at month 1. I know it seems like a cop-out to explain them away, but these are people who had particularly aggressive disease despite their initial biopsies. And all of these men had very rapid progression. So it's not bad when you look at a guy who's got low-risk disease and say, you know what, if we go on an active surveillance You've got a 99% chance you're going to be okay and a 1% chance that maybe you're making a bad decision. Risks, everything's got risks and benefits. The risk with active surveillance, I think some of it's just psychological. Can your man sleep okay at night knowing that he's living with his cancer? The interesting thing about studies that look at this is that the men who are treated are just as worried at night as the men who aren't treated. The guys who have surgery, they worry every 3 months about that PSA. Is it going to be 0? And with radiation, worry because how do you determine what to make out of that 0.2 that went up to 0.3? So the more they look at it, the amount that people are worried isn't really any different if you're on surveillance or active treatment. Risk of growth and progression, about 22%. And the risk of progression beyond our ability to cure is minimal. It's 1%. You might argue it's even less, that none of those men were curable to begin with. So basically, select men who have low-grade cancer really can initially avoid treatment if we're going to watch you closely, get frequent PSA, frequent prostate exams, prostate biopsies on a schedule. The risk of the cancer progressing beyond our ability to cure is very low when you're on this type of protocol. And the benefit is that some of these men can avoid the risks and side effects, incontinence, impotence, bowel, bladder dysfunction. Whether they're getting 5 years of no risk, 10 years of no risk, or possibly for the rest of their life, all of those I think are definitely big benefits. And to me, in my summary, despite the criticism from Dr. Williams, the standard is we always say that prostate cancer is overdiagnosed and overtreated. But I think it's important that patients deserve to see people who understand that this may be the case and not automatically recommend radical treatments just because the cancer is there. Thank you very much.